Hi, my name is Kohli, and in today's Case Connections video, I will be addressing cases 2 and 3. Starting off with case 2, we learned that the 4-day-old infant had a newborn screening in which high levels of phenylalanine were noticed. They diagnosed the infant with phenylketonuria. The family says there is no history of phenylketonuria, indicating this is not likely due to a mutation in the genome. The first question we are asked is what amino acid may become essential as a result of the presentation of high levels of phenylalanine. From this diagram, we see that phenylalanine synthesizes tyrosine. High levels of phenylalanine indicates that the phenylalanine cannot be converted into tyrosine due to some deficiency. This then makes tyrosine an essential amino acid because it cannot be produced in the body anymore. The patient is then put through phenylalanine dietary restriction therapy, which effectively reduced the phenylalanine levels to within the normal range. We are then asked what is causing the presentation of phenylketonuria. This diagram does not show it, but phenylalanine hydroxylase is the enzyme that catalyzes this reaction along with the cofactor BH4, which is shown. As a result, the two ways in which a patient can acquire phenylketonuria would be due to a genetic mutation that encodes for the enzyme phenylalanine hydroxylase, which is classical PKU, or a loss of the enzyme that is responsible for regenerating BH4, both of which will lead to a buildup of phenylalanine. Then we take a look at another patient that is suspected to have PKU. Patient B. A BH4 loading test was done on both patients with the results as shown. So a BH4 test basically adds a synthetic cofactor, meaning it acts as tetrahydrobiopterin, or BH4, would in the body. This synthetic cofactor was administered to the patients shortly before they ate a meal, and the levels of phenylalanine were observed afterwards. Patients A and B started at the same level of phenylalanine in the blood, and then patient A's levels slowly increased. This indicates that the cofactor did not make a difference in decreasing the levels of phenylalanine in the patient, and that BH4 was not the problem in the first place for the patient. This is why reducing the phenylalanine in her diet led to a decrease in the levels of phenylalanine, and her PKU is a result of a deficiency in phenylalanine hydroxylase, or a mutation in the gene that codes for it. Patient B's levels of phenylalanine, on the other hand, are rapidly reduced once the synthetic cofactor is added, indicating that it is being broken down into tyrosine and everything is functioning normally. As a result, we can conclude that this patient shows signs of PKU for different reasons than patient A did, and that the problem in patient B was that BH4 was not being regenerated and could not be used. The phenylalanine hydroxylase is working and just needed some BH4. Looking at this diagram once again, we see that there are two types of ways PKU can occur, and by performing the BH4 loading test, we were able to determine the reason each patient had PKU. However, it should be noted that although BH4 is added and phenylalanine levels are back to normal in a case such as patient B, this does not resolve all the symptoms of PKU. As we can see, tyrosine goes on to be the precursor for major neurotransmitters such as norepinephrine, epinephrine, and melanin. But BH4 cannot ensure that these neurotransmitters are now being produced normally because synthetic BH4 cannot pass the blood-brain barrier. Since these neurotransmitters must be produced in the brain, it still leads to all the other side effects of PKU that results from a loss of production in these neurotransmitters. Now we are going to move on to case 3. In case 3, we are looking at a 47-year-old male with severe pain in his big toe. The pain only started last night and was not due to any trauma, and is continuing to increase in severity. His physical exam and laboratory findings indicate that he has gout. Gout is the result of excess uric acid in the body, which is also known as hyperuricemia. This overproduction of uric acid can happen in one of three ways. One could be due to the overproduction of purines, the second could be decreased salvage of purines, and the third could be due to a decreased urinary excretion of uric acid. And looking at the pathway of uric acid, in the production of uric acid, we see that it is involved in the process of salvaging purines. So the increased salvage of purines will lead to an increased production of uric acid. As a result, we can easily eliminate the second choice, which said that the buildup is due to the decreased salvage of purines. In order to decide between choices 1 and 3, we need to look at the urinalysis. In the urinalysis, we see that the plasma urate levels are high and urinary uric acid levels are very low. Overproduction of purines increases the levels of uric acid in the blood. However, it should not interfere with the functioning of the kidney. If the cause of gout was due to an overproduction of purines, then the plasma urate levels would be high, but the urinary uric acid levels should be normal. Overproduction of purines means increase in PRPP synthetase, so more purines can be produced, which increases the number of purines that need to be salvaged. Hypoxanthine guanine phosphoribosyl transferase, or HGPRT, is an enzyme that is involved in the salvage of purines. A deficiency in this enzyme results in the Lesch-Nyhan syndrome. This presents an extreme case of gout as uric acid is being overproduced due to an increased PRPP accumulation, which is what is being referred to in the first choice. The first choice indicates that there is a metabolic problem. Additional testing can be done, however, to see if there is an HGPRT deficiency to better eliminate this choice. However, the high levels of uric acid production due to an overproduction of purines will indicate a high excretion of urinary uric acid as well, which is not seen from this patient's urinary uric acid levels, which are lower than normal. An impaired urinary excretion of uric acid, we are indicating that this is more of a problem in the kidney. The urinalysis is consistent with the increased levels of uric acid production in the blood and also shows that since the levels of urinary uric acid are very low, the intermediate step, which lies in the kidney, is not functioning properly. Choice 3 best supports this by saying the explanation is due to decreased urinary excretion of uric acid. Then we are told that the patient only recently switched from diet soda to regular soda, and he drinks nearly 4 to 5 liters of soda a day. Although he switched to regular soda because he did not want to consume fake sugar, he instead consumed an abundance of real sugar, which comes in the form of fructose in sodas. Drinking 4 to 5 liters of soda a day leads to an abundance of fructose in the diet. Fructose is seen to tie into gout through the means of the pentose phosphate pathway. Gout can also occur due to insufficiencies in the pentose phosphate pathway, in a disease we have seen before in this course called Van Gierk's disease. This disease is the result of a deficiency in glucose 6-phosphatase, which increases the production of ribose 5-phosphate in the pentose phosphate pathway. Ribose 5-phosphate will lead to an increase in purine bases and then an increase in purines that must be salvaged, which will increase uric acid production. Fructose is also part of this pathway and therefore can also lead to the same problem because fructose is present in the reversible and non-oxidative portion of the pentose phosphate pathway. The reversible nature of this part of the pathway can mean that the overproduction of purines is also possible through this mechanism, and since his diet only recently changed to this, it can explain why all the uric acid is building up in his body. In a paper I read titled The Epidemiology of Uric Acid and Fructose by Dr. Rowe, I also discovered that high insulin can lead to less excretion of uric acid in urine, which can also point to how the high levels of soda in his diet led to low levels of urinary uric acid. High fructose consumption is consistent with gout, and therefore this is the underlying cause of his recent case of gout, indicating it is more likely to be a cause of problems in the kidney as opposed to a genetic mutation causing deficiencies in certain enzymes in different pathways, confirming choice 3 as the best explanation for the presentation of gout in this individual. That is all. Thank you, and here are my references.